All right, so today I'm going to talk about thank you for the introduction. I'm going to be talking about the challenges of enteral feeding in very low birth weight infants. Can everyone see my screen?
Yes.
Perfect, thank you. So I have nothing to disclose. We'll start out by talking about the growth goals for term versus premature infants, the nutritional requirements for our group of patients, how we advance enteral feeding and the importance of protocols, and then move to how to deal with feeding intolerance. So I'm here as a dietitian today talking to you about nutrition. So what is our goal? What are we trying to do for premature babies? We provide nutrients to approximate the rate of growth and composition of weight gain for normal fetus of the same postmenstrual age. We do this by maintaining normal concentrations of blood and tissue nutrients, trying to achieve optimal development. So I'm starting out right into a case, and this case of infant K is going to lead us throughout the presentation on looking at our objectives. So I have an infant who was born at 29 weeks and 5 days. He was 1,630 grams, put him above the 85th percentile. His head circumference was 28 and a half, about the 81st percentile. Length was 40 centimeters, which put him at the 68th percentile. So he was all appropriate for gestational age on his growth chart at birth. He had RDS, was on CPAP for the first 9 days of life, came off, was on room air. And then when he was born, it was because he was premature rupture of membranes. He was breech, so he was delivered via C-section, and he had delayed cord clamping for 60 seconds. So when a baby like this is born into our unit, the first thing I look at is what are our growth goals? How do we want this infant to grow? So a term baby would be 20 to 30 grams per day, but he's premature, so his goals are 15 to 20 grams per kilo per day, following a weekly head circumference of 0.9 centimeters per week. And knowing that it is physiologic for these babies to lose up to 15% of birth weight within the first week of life. So growth chart is what we follow so that we can see a trend. What do they look like at birth? And then how is their trend of growth for head circumference, length, and weight over time? And are they following their curve? So this would be the WHO growth charts, appropriate for a term infant, but this baby's premature. So for infant K, we want to follow that head, weight, and length, but we use it on the boy's growth chart. The Fenton charts are what we use. So this is where he plotted. He was just over that 1,630 grams. I would expect diuresis and then to be following his curve. His head circumference was looking here around just below that, around the 80 percentile, and length here. And to get an exact percentile, we use a program called Pediatrics online. So you can put in the exact gestation, the size of the infant, and it'll give you an exact percentile. So the growth chart is nice to have a trend, and then we can use Pediatrics or other online applications to give us an exact percentile. So that's my growth goal. Now, what are nutrition requirements for this baby? So we know that term babies need about 100 to 120 calories per kilo per day, protein 1.5 to 2 grams, but he's premature, so his requirements are a lot higher. So we have 3 different categories that we break it into: less than a kilo, 1 to 1.8 kilos, and over 1.8 kilograms. Sometimes the weights aren't within an exact amount or what we would expect if they're small for age, so we can often look at the gestation as well. So for this little guy, he was in the 1,600 grams, so he'd fall in this category. Our calorie goals are 110 to 135, and his protein goals would be pretty much doubled of what a term infant would need, 3.5 to 4 grams. So now we've got our growth goals, we've got our nutrition goals, calories and protein, and knowing we need a lot of extra vitamins and minerals as well. But we got to get started with fluids. So baby's born, we start ordering our TFI, we would get an IV in place, and for him, we would start at about 80 mils per kilogram per day. So day 0 of life, we call delivery day. And then on day 1, going up about 20 mils per kilo, and so on until we reach our goal of about 150 to 165 mils per kilogram per day. But we do know that we expect daily weight loss within the first week of life. As I said, that's normal physiologic. And we can use the weight to help us determine if we should go up. So if we see a baby gaining weight within the first day, we probably shouldn't be increasing that. And we need to follow the fluids and electrolytes. So we may go a little bit quicker on this TFI or a little bit slower based on those electrolytes. We do know that premature infants have higher insensible losses, so they have more significant prolonged diuresis compared to a term infant, and can take up to 3 weeks, especially for the very low birth weight infants, to start gaining weight. So then we want to start initiating feeds. So we know we've got IV in, we're starting our IV fluids, we're using, for this patient, BD10, and then we're going to start oral feeds. So for all babies who are born greater than 2,500 grams at our center, if we can, we would start feeding them on demand, but most of them are probably not going to be strong enough at that initial point. So we would initiate a feeding volume of about 2 to 3 mils per kilogram per day, and increase. The literature shows us 10 to 35 mils per kilo. Our center uses about 20 mils per kilogram per day. So we're not too slow or too fast based on literature. So then we would increase that volume every day to meet our TFI, noting that some of these babies, like I said, wouldn't be ready to ad lib demand because we're not seeing that suck, swallow, breathe reflex develop until about 33 weeks gestation. So now for the smaller ones, or low birth weight, who are less than 2.5 kilograms, we have a standardized feeding advancement. Our advancements are, like I said, 20 to 30 mils per kilogram per day. And we know that just having a standardized advancement does reduce the risk of feeding intolerance, feeding complications, and necrotizing enterocolitis. And there's a most recent article just this month from Perinatal 2020 illustrating that same. So now we break down. So not all babies are going to be fed on the exact same volume, or all less than 2,500 grams. So at our center, we break it down into smaller subgroups. So our first group is the 1,500 to 2,500 gram infant. We would start an IV initially of D10 and meeting that TFI protocol on that table I showed earlier. Then we would wean IV as we're increasing our enteral feeds to maintain the TFI. Infants who are less than 1,500 grams, 1,250 to 1,500, we would start TPN. All babies less than 1,500 grams, we would definitely start TPN, an automatic start. And that gets started right in the resus room. We have basic start bags that are ready to run. As soon as the line gets in, they start that, and then they would start a standard bag and an individualized TPN after that time. As far as starting enteral feeds, for these infants, we would start a trophic feed or minimal enteral feeds, and that would be done for the first 24 hours just to get the priming of the gut started, and then we would follow our protocol feeds. For babies born less than 1,250 grams, same thing, start TPN and lipids, but our mineral enteral feeds or trophic feeds would go for at least 72 hours. And we would reassess this after the 3 days of trophic feeding if the infant needs to be longer on that before starting our protocol feeds. And for this group, less than 1,250 grams, instead of feeding them every 3 hours, it'd be every 2 hours. And we do start with bolus feeds. So they would get their feed on that hour and it would be provided bolus. So these protocol feeds, this is what our center uses. This is an example of what the protocol is. So if we order to start protocol feeds, then we have individualized kind of a script for what the nurse would feed, what the baby would get. So for infant K, he was just over 1,600 grams. So he fits in this feeding schedule for his birth weight, and he would stay on this until he reaches his full feeds. So like I said, the first day we would start our TFI, probably about 80. D10 would be running to meet that volume. When we are starting our enteral feeding, so this would be 4 mL. So on that first feed of the day, they would get 4 mLs, and the nurse would subtract that volume from the IV. and then she would increase, then feed later, maybe 3 mLs. And these volumes were based on needing that about 25 mils per kilogram per day. So this infant, the infant K, would take 6 days to get up to our full goal of 150 TFI, full enteral feeds, and no longer needing an IV. So while we're doing this is going to be fed, we're less than 33 weeks, we're about just over 29 weeks gestation, so we're going to be using a feeding tube. Now, while that feeding tube's going, we're not using the mouth at all. Feeds are going right into the gut, right? So we need to continue to use the mouth. The mouth digestion, I always say, digestion starts in the mouth. We need to have the secretory. We need to provide immune therapy. So oral immune therapy is the administration of mother's colostrum, of her milk, by placing small drops directly into the oral mucosa. So the drops of milk get absorbed into the mucous membranes. There's lots of protective effects. I just highlighted a few here, but the most important, it would be reduction of nosocomial infections and necrotizing enterocolitis. And we always do this when we're not using the mouth. So again, like digestion starts at the mouth. So now we know our goals, our feeding advancement. What are we feeding? So the first thing we look for is mother's own milk. Multiple benefits. Again, I could talk for days on the benefits of human milk. Immunoglobulins, lactoferrin, oligosaccharides, reduces bacterial growth, and is best tolerated, especially by our premature babies. However, for a premature infant, it does not provide enough macronutrients and micronutrients. So we need to fortify. If we don't have mother's milk, at our center, we use donated breast milk. It's been screened and pasteurized, and consent is required for this. And we do have special criteria for use, and it's for all babies who are born less than 2 kilograms, or if there's other medical indications per the physician or our dietitian group. And those could be anything that has poor perfusion to the gut. Then we would have a discussion if this is appropriate infant to receive donor breast milk. So like I said, we have our human milk, and now we would be fortifying that to get our micro and macronutrients. So we're looking for more protein. Like I said earlier, we need double the amount of protein that a term infant would require. The human milk fortifier provides a bit more fat, and then vitamins and minerals, doubling our calcium, phosphorus, sodiums that human milk alone provides. We use the human milk fortifier for all infants less than 35 weeks, or if they're born less than 2.5 kilograms. We continue until they're over 3.5 kilograms. The sources of protein would be milk protein isolate and whey hydrolysate, so bovine source. The carbohydrate source is small amounts of corn syrup, and there is some lactose in it, but it's a little bit less concentrated compared to a regular formula. And then the fat source is soy and some MCT oil. Another option we have is human milk fortifier. So it's not a bovine fortifier, it's fortifier made from donated human breast milk. We particularly use it for all infants who are very low birth weight. And in our center, we use it for infants who don't tolerate the bovine HMF. But there's other centers across the world who are using it as a standardized protocol for all babies less than a certain gestation. There's different uses that they can use, but it's intended for low birth weight infants who are less than 33 weeks. And it's to provide a full human milk diet. So now what do we feed if we don't have human milk? Well, we have our bovine fortifier, or our bovine formulas, term infant formula, preterm infant formula, and specialty infant formula. So what are our options for premature babies? The premature formula is a higher nutrient dense, so it tries to mimic the micro and macronutrients of human milk with our bovine fortifiers. Again, we use it for infants less than 35 weeks or less than 2.5 kilograms. The other option is a premature high protein formula, and it has a protein source that's higher. It can bring us up with a 150 TFI And this product would give us exactly 4 grams of protein per kilogram per day. So we don't have to add any extra fortifiers to that product. Then for babies going home who are born less than 1,500 grams, we would use a preterm discharge formula. For other specialty formulas or options, generally are lactose-free, soy-based, a hydrolyzed protein with MCT oil, and all of those products would be cow's milk based, or the hydrolyzed ones would be cow's milk based, but the protein is hydrolyzed. And then there's the amino acid based formula. It is not based from cow's milk at all. So back to our infant K. So that's overall our options. We have our growth goals, nutrition goals, how we advance feeds, what our feeding options are. So what happened with infant K? What makes him special? So on day 1 of life, we started protocol feeds. We got consent for donor milk. We had a little bit of mom's milk. So we started on protocol. He was over the age to need minimal enteral feeds. So we started right into that protocol feed, like the one I showed you. We advanced on that protocol. At day 5 is when we started adding our bovine fortifier. We had our fortifier at half concentration first, monitor for about 48 hours, make sure it's being tolerated. It was, so we increased our fortifier and we were at our goal volume by day 7. We still didn't have enough protein, so we added a protein fortifier, which our protein fortifier is a hydrolyzed protein. It went well, so the next day we optimized it further. So now by day 9, we were at our goal nutrition and our goal growth. The nurse did note that there was slightly looser stools with the addition of our bovine HMF. We had 1 to 2 small spit-ups a day, but just mouthfuls, nothing that would stop us at this point for changing any feed regime. At day 14, for our criteria, this baby receives 2 weeks of donor breast milk. So 2 weeks was passed. We still didn't have much of mom's breast milk. So we started weaning off of the premature formula, or we started weaning off the donor breast milk to our premature high protein formula. And the way we do that is we wean by 25% every 24 hours to the formula to have a slow introduction, and we follow tolerance. We saw that there was some slightly looser stools. The nurse reported a little bit of reflux, but no big emesis, no real thing that was going to stop us from feeding. So we continued weaning off, and by day 17, baby was on all formula. Most infants, this goes fine, but he was special. So by day 18, he went NPO. So this was 1 day after he was full formula fed with our premature high protein formula. He went NPO. He had mixed blood found in the stool. There was no fissure. It was quite a on the right lower quadrant, left abdomen, query gas and stool, or pneumatosis intestinalis. So looking at this, the baby was kept NPO, TPN was started, and antibiotics were started. Did blood work along with that, but I think we got the x-ray back first. The CRP was less than 1. Right? Hemoglobin 168, platelets 574, so slightly high, but nothing to concern. And we took a peek at the eosinophils and we saw that they were 3.9%. So normal would be 3% or less. This was around there. So by day 19, the CRP blood work was repeated. CRP was 2, had in rows. Hemoglobin 145, platelets are fine. The eosinophils were very high at 16.5%. Sometimes interpreting eosinophils can be very challenging, but that's happening. So they increased to 16.5%, quite high. This patient did have a normal physical exam, however, it didn't look like a typical neck picture. So we did ask for an intestinal ultrasound. That report showed no evidence of neck, no bowel thickening. So we thought, well, is this cow's milk protein allergy? Especially with the platelets were slightly high, the eosinophils were high. So we thought, well, let's restart feeds. This does not look like typical neck. So we did restart feeds at 25%. we increased that 20 mils per kilogram per day. And we used hydrolyzed formula this time. We didn't use the cow's milk preterm high protein formula. Day 21 to day 26, the blood appears to be reducing. The patient is meeting growth goals. But then on day 27, so it's about a week later, the blood increased, and it was quite a bit more than the first time. So abdominal x-ray was done. The report was dilated bowel loops, air bubbles within the bowel wall, suspect neck of the distending distal colon. So they're very specific here. So baby was put on NPO, TPN was started, antibiotics were started again. The blood work though, the CRP was less than 1, hemoglobin was 117, so a little bit, but we've been losing some blood here. Eosinophils were still high at 10.5%. So the next day, we got an intestinal ultrasound performed, and it was normal. There was no air bubbles seen, no abnormal gas patterns, nothing was seen there. So we did resume feeds, we stopped antibiotics again, and this time we changed to an amino acid-based formula, so not cow's milk-based at all. And the baby did well. We did increase the calories because we were still in that prem phase. We weren't getting enough with standard strength. So we increased our concentration over time and the baby started growing fine. So we did outpatient follow-up with our allergy team. And then I transferred from inpatient dietitian to outpatient dietitian on discharge. So talk about feeding intolerance. So what is our definition? Feeding intolerance definition is very different depending on what article you look at. But overall, what we use here is it's a combination of clinical signs suggesting the inability to tolerate enteral nutrition. It might include abdominal distension, discoloration, visible bowel loops. This baby didn't have any of that. New onset of frequent emesis or frank blood in stool. So we saw the blood in the stool. So when you see that, it's blood in stool neck, it's a cow's milk protein. And we always make sure that there's no fissure or tear in the area. None of that was happening either. So we try to, at our center, we always try to avoid NPO. We know that when you go NPO, it puts the gut into starvation mode. It slows peristalsis, which increases further bacterial growth. It can also increase your risk of neck, prolonged feeds, and increases your risk for sepsis. The longer you're not at your goal enteral feeding, the longer you have to not have an IV in and probably TPN. So what do? You can reassess your feeding volume. Should we decrease the volume? Do we go back to a trophic feed? Or do we change our feeding type? So to know what to do is we try to use all the tools possible. So abdominal x-ray with an intestinal ultrasound and looking at the blood work. If we would have just followed the abdominal x-ray, this baby would have stayed NPO for 2 whole weeks, antibiotics 2 whole weeks, and TPN for 2 whole weeks. That would have been our normal practice. But with the blood work and the intestinal ultrasound, we were more convinced that this was not neck and that we could safely start feeds again. We just needed to determine what was the right choice. Do you use amino acid-based formula or do you use a hydrolyzed formula? Usually our first defense is we would go to the hydrolyzed formula, see how that's tolerated, and then go to your elemental or amino acid-based after that if problems still occurred. So in conclusion, we use a team approach to neonatal nutrition, growth, development. The neonatologists and our dietitian team work very closely together. We're on rounds every day with them. We use our standardized protocol feeds for all babies less than 2.5 kilograms. And all babies down to like 400 grams, we would have that same type of slip that I showed of the feed advancement. And it would be individualized for their size. We avoid NPO when appropriate, and we use all of our tools to avoid the NPO. So look at feed intolerance, look at neck versus allergy, and all those tools. So there's some of my references, and thank you. That wraps up my